Now, I've shown this case before, and I'll ask my partner, Dira, to solve this. The patient that I showed before had a transitional kyphosis, and Dira has some thoughts on how to solve this problem.
Well, I've been given the task of looking at non-fusion options for transitional kyphosis, and I don't really know if this is an enviable one or an unenviable one because there's really no literature on this topic. Start off with just a couple of cases. This is a 59-year-old Caucasian female who has Sjogren's syndrome. She's been on prednisone for a long time. She's also been on methotrexate as well as alendronate. She's got chronic back pain with buttock pain, difficulty with ambulation, difficulty with sitting and standing tolerance. She's had 2 laminectomies, each of which provided her a little bit of relief, but her symptoms came back quite quickly. And you can see on these long-standing films that she has both coronal as well as sagittal imbalance. Her DEXA scanning shows that her T-score at the hip is minus 0.9, and her T-score at the lumbar spine is positive 0.1. You can give you a little bit better of a look at her lumbar spine. She's got a degenerative scoliosis, post-laminectomy scoliosis of about 50 degrees. You can also see, certainly on the CT scan, although that's a supine reconstruction, that she does not have much thoracic kyphosis. In fact, she's a little hypokyphotic. She does have thoracolumbar kyphosis of approximately 20-24 degrees, and her overall lumbar sagittal alignment is somewhat kyphotic as well. So she ended up having a T9 to the sacrum reconstruction, complex reconstruction with multiple levels of transforaminal lumbar interbody fusions. She had a near complete correction of her scoliosis. She had a nice restoration of her lumbar lordosis and initially did quite well for the first 4 to 5 months. And this is, I apologize that I didn't have long films on her post-op, but her intraoperative fluoroscopy shows that she certainly looked as though she was neutral at the level that was stopped. And if we went back to her pre-op standing films, we'd see that she was fused into a neutral zone. So she did pretty well for about 4 to 5 months, and then without any trauma started complaining of both some low back pain as well as some upper back pain. And you can see actually right over here on this CT scan reconstruction that she has a fracture of her upper instrumented vertebral body. The adjacent segment does not seem to be involved. She also has actually, as time went on, she developed a fracture actually above the level of her instrumented vertebral body as well. She's quite debilitated from all of her medical issues and really did not want to have any further surgical intervention. We actually braced her with a Jewett brace and gave her some time, and clinically she actually healed. Her pain became much better, narcotic requirements decreased. She actually had a flare-up of her rheumatologic disease, and her immunosuppressives were changed around, and she seems to be doing quite well. We had actually entertained the idea of doing a vertebral body augmentation on her, but she seems to have healed for the time being. Her thoracic kyphosis significantly increased, as you can see, and it does seem to be focused above the level, obviously, of her prior fusion. And she's now at about thoracic kyphosis of 65 degrees and with some positive sagittal imbalance as well, but she seems to be holding her own. Now, this is a 78-year-old Caucasian female who's had an L1 burst fracture and presented to us some months after her initial injury. She was initially neurologically intact, and when we saw her, she had a subtle conus injury and was really having a lot of trouble with her activities of daily living, had no tolerance for sitting or standing, increased requirements for narcotics, increased requirements for her antidepressive medication. She's actually on alendronate as well as oxycodone. And interestingly enough, here's another good discrepancy in terms of her DEXA scanning on her hip as well as when compared with the DEXA scanning on her lumbar spine. Her T-score, her hip is minus 2.4 and her T-score in her lumbar spine is 0.6. And this is a well-known discrepancy in terms of anytime you look at a lumbar spine, the degenerative changes really can falsely elevate your bone density measurements. And from a coronal standpoint, she appears to be well balanced. Her sagittal balance is quite positive, and unlike the other patient, she has a significant amount of thoracic kyphosis. She underwent a T10 to the sacrum reconstruction with a L1 vertebrectomy via costrotransversectomy approach. And initially, for about the first 6 months, she did quite well. She was mobilizing, some decreased narcotic requirements, and then, unfortunately, she took a fall and sustained, as you can see over here on your right side. I don't know if you can see it very well there, but she has a fracture of the vertebra above her upper instrumented vertebrae. And she did not have this this was her 2-month follow-up visit. So we tried to actually place her in a Jewett brace. You can see this actually a little bit better on this CT scan reconstruction. She actually has a cleft and vacuum phenomenon within that vertebrae, and her sagittal balance is somewhat slightly more positive than it was before. She was actually never really completely corrected from a sagittal standpoint. So she really was, unlike the other patient, was really unable to mobilize from a clinical standpoint, was not really progressing in terms of her pain control, and was in no shape to undergo a long revision procedure. So we offered her a vertebral body augmentation, so she ended up having a cavitation procedure with bone filler at the level above, and this actually did quite well for her. Her narcotic requirements decreased. She ended up having an improvement in her function. Still fairly depressed, unfortunately, at the turn that her life has taken in the last 18 months. But in general, she's managed to avoid having another long reconstructive procedure. We don't know how long that'll last for, obviously. So Dr. Wilson-McDonald actually talked quite a bit about this. Obviously, there are a number of issues with proximal junctional kyphosis, why it happens. In terms of the risk factors and incidence, we really don't know what they actually are, but this was definitely a hot topic at the SRS this year. These two studies, first two studies that are up here, he actually already alluded to. They did note, this is all from the St. Louis group, all of these studies that I'm presenting did note an association with age greater than 55 years and all pedicle screw constructs, but really no difference in outcomes. Certainly hybrid constructs they thought were tended to be more progressive, but the incidence was essentially the same. Looking at another, in a little bit of another vein that Jens had alluded to earlier, is there a way that we can figure out which level is going to be the most likely to avoid proximal junctional kyphosis? And again, the same group, albeit in a retrospective manner, looked at 90 patients, all fused for adult deformity, all from the thoracolumbar junction to the sacrum. They did note the L1 group was significantly older. This could be bias in terms of length of procedure, certainly. But they did not notice any difference in proximal junctional kyphosis, sagittal alignment, or in terms of their outcome measures, and they were using the SRS-24. So what they recommended, which is what we all essentially know, is that we need to fuse to a neutral and stable vertebra in both the coronal as well as sagittal planes. Another study out of the same group looked at a variety of lengths of fusions and adjacent segment degeneration. So then they defined adjacent segment degeneration as spondylolisthesis, significant spondylolisthesis, spinal stenosis, or significant disc degeneration. Clinical symptoms, they talked about spinal stenosis and intractable back pain. And they noticed about 44% of patients with adjacent segment degeneration, a little bit over half of these were symptomatic. Their hypotheses were that long fusions and more proximal fusions, as well as circumferential fusions, would probably lead to more adjacent segment degeneration, but they really didn't find that any associations. And there was an adult deformity supplementation to spine in the last month or so where they had debates about these very topics, as well as some review articles. And one of them was out of Rush, where they looked at, started out looking at a retrospective review of 38 patients with, they all had long posterior spinal fusion, so they defined those as longer than 5 vertebral bodies. They were all over 65 years. This was kind of a potpourri of patients, so it was a little bit like comparing apples to oranges, unfortunately. Although they mentioned decreased bone density, they actually did not have any objective measurements of bone density. They did not mention any treatment for osteoporosis. And they did find patients with fractures of the upper instrumented vertebra, as well as the adjacent segments, and about 6 of them with progressive thoracic kyphosis without any focal lesion. So what they recommended, based on this retrospective hodgepodge, I think, of data, is that you, again, want to fuse to the neutral and stable vertebra, and then you should really counsel your patients that there's a good chance that you're going to have to extend their fusion as needed. So in terms of tips for minimizing proximal junctional kyphosis, obviously you don't want to fuse into a kyphotic segment. Really want to evaluate how degenerative your disc is that you're planning on stopping at and include that. Less reliable is whether or not you have subtle changes on your MRI, subtle signal changes on your MRI, whether you need to include those discs. In terms of treating osteoporosis, this has become an issue in terms of do you continue treating them through the fusion. Again, another study out of St. Louis presented at the SRS this year looked at was an animal study looking at the ability of BMP to actually overcome the inhibitory effects of alendronate on a fusion in a rabbit model. And they found that the BMP actually indeed was able to inhibit the likelihood of non-union. The caveat on this is that this was actually sponsored by the company that markets BMP, so you can take what you want from that. In terms of supplemental fixation and vertebral body augmentation, these actually have been shown to help in terms of your loss of pullout. In terms of pullout strength, they both either or will increase your pullout strength of your pedicle screws by approximately twice. But this actually only obviously addresses one etiology of proximal junctional kyphosis. So obviously there's still a lot of questions. How much do we correct these patients? We have a lot of very powerful instrumentation these days, but we're still really beholden to the bone-screw interface. In terms of bisphosphonates, what's the role of bisphosphonates? Do we stop them beforehand? There have been some investigators that have suggested stopping bisphosphonates before you actually fix a hip fracture. What's the role of BMP in these patients? Which bone filler do we use if we're going to augment? Which one do we use? Do we want to go with the calcium phosphate? And how much osteoporosis is too much? There are really no guidelines for this. Where do you measure it from? How much is too much? When do we decide that, you know what, I'm sorry, we just can't help you? And then, as Dr. Wilson-McDonald also alluded to, there could be an indication for motion preservation technology in these patients. And maybe this could be not only for treatment of the actual PJK, but certainly for prevention of it. And one of the flexible systems that is not approved for FDA use for this indication is the Dynassist system. And one can imagine that you could possibly use a motion preservation system above the level of a fusion. Again, this is an off-label use of this device. And certainly disc arthroplasty in the future, and this device is obviously not yet approved for clinical use by the FDA, and if it is approved, I doubt they'll actually approve it for this use, but this is a cervical disc arthroplasty above the level of fusion, but it can make us think about possibilities for the future.
So let me just shoot a couple of questions at you, Dear. Do you mind staying up here right away for ease of microphone use? You mentioned the bone mineral density tests, and again, you showed two examples which were kind of conflicting and frustrating. What is too little? Should we use bone mineral density as a definitive no in terms of surgical intervention?
I really looked for data on this. I was hoping there would be something out there in terms of how much is too much or how little is too little. There's a debate. Obviously, you really can't really measure it in the lumbar spine because it's known that those measurements are falsely elevated. My feeling is that if it's an elective procedure and the patient is in the osteoporosis or even osteopenic range, you probably owe it to them to really try very hard to improve their bone mineral density. If you can't, and it's obviously an emergency, you might want to try doing something like what James showed earlier, which is try to leave out your instrumentation. You might be much less likely to cut out. You're not actually really relying on a bone screw interface and brace the patients afterwards. But it's a difficult problem, and our patient population is aging, and I think we really need to think about this.
It's my special privilege to introduce our next speaker, who I'm sure is going to talk about non-FDA approved items. Lieutenant Colonel John Devine is next up. He's going to talk about surgical options for caudal breakdown. As you all know, John Devine is from Madigan. We very much cherish our collaboration with Madigan. So, John.
I want to thank Drs. Chestnut and Chapman for inviting me down. I'm actually surprised that I was invited up. I know that Dr. Chapman is actually, he doesn't hold a grudge now because about 8 years ago I dropped a big harms cage on the floor in his OR. And so I know those hard feelings have passed because he's invited me up, but it took 8 years. So, So he asked me to talk about really the application of artificial disc replacement for degenerative segments adjacent to scoliosis fusions in terms of the treatment for caudal degeneration. And I was kind of asked the question because by virtue of my practice, I don't have to deal with third-party payers, and so I've been able to do some disc replacement at my institution. And with my experience during my fellowship with the FDA study, I could be considered a local expert, and that's about it. So the question is really, is this feasible? It certainly is tempting, but is it the right thing to do? So we talked about, in all the studies, or on all the lectures today, really adjacent segment disease, and we know it occurs. We know it occurs both rostrally and caudally. And we know for floating lumbar fusions, as established by Drs. Giselli and Wong at UCLA, that the rate probably is about 4% per year over 10 years for actually degeneration requiring surgical treatment, not just radiographic findings, but requiring surgical treatment. And really that's the best data that we have. Everything else is extrapolated from this data. The true prevalence for adjacent segment disease in caudally and idiopathic scoliosis is really unknown. Part of that is the patients that do the surgery don't necessarily follow those patients after they're 21 years of age. They go on to other types of surgeons and other institutions, and so we don't have that follow-up or the history that gives us a true prevalence. But in that idiopathic group, it's probably more common caudally than it is rostrally for posterior spinal fusions, especially those ones that are done from T4 to L1 or L2 or L3. And it probably increases with the number of lumbar levels fused because you're decreasing the number of motion segments available in the lumbar spine. Chuck Edwards, when he was a fellow with Bridwell, published in 2003, what is the fate of the L5S1 disc if you fuse all the way to the last motion segment? And it's not very good. I mean, there's a 61% revision rate at that level within 6 years. So now we'll change speeds and move to physiologic spine reconstruction. And really, is this applicable to use at the caudal end of a large scoliotic segment? Really, the ideal candidate for a disc replacement is a single-level degenerative disc. Discogenic pain concordant with a discogram with none of the discriminators or contraindications, such as osteoporosis or instability, previous infection, or tumor. And this is just a case example. This is actually the first patient I did at Madigan almost 2 years ago. And you do a few of these. My experience with the FDA study excited me about this technology, and so I brought this into my practice at Madigan. And within the proper indications, the results can be really outstanding, and thus increases your enthusiasm. And then you start to maybe use the device outside of its actual indications, not necessarily approved by the FDA. So in the ideal candidate, but with a little more advanced disease, and frankly, this patient wouldn't have been included in the FDA study because she has too much disc collapse. She's a 39-year-old triathlete who basically refused to have a fusion until disc replacement became available. And we did a disc replacement on her, and you can see excellent restoration, but she's not really a candidate. This is outside the line. So you get good success with playing outside the lines a little bit, and then you stress the lines a little further. And here's a patient with non-contiguous levels, really generalized back pain who's changed his job twice, gone from an infantryman to a hospital administrator, which was bad for me, frankly, because then I saw him every day. But he has 2-level concordant discogenic pain with 3 other normal levels in the lumbar spine, and so we did 2-level lumbar disc replacement. So as you can see, when technology becomes available to the general public, the indications will get stressed. And for right or wrong, if you have a hammer, you're looking for nails that you can treat with that hammer. And again, this guy was very happy with his outcome, and he's almost 18 months post-op now. So we haven't done this at Madigan, but it's been presented in the literature, and that is using this technology, motion preservation technology, adjacent to fusions for adjacent segment disease. The earliest was Dr. Kim in 2003, who really just showed preliminary results from 5 patients with 6-month follow-up. And his conclusion was, hey, in the early going, we have a 63% improvement in our ODI, but we have a very short follow-up, so we need more patients and we need more follow-up. And Bertignoli did just that, having just produced in recent literature, prospective longitudinal study with a little higher numbers, 20 patients, 18 with 2-year follow-up. The average age was 50. And again, using disc replacement technology for adjacent segment disease, in this case above lumbar fusions. And he showed improvements at every step in the follow-up, 3, 6, 12, and 24 months in ODA, VAS, and patient satisfaction. It didn't really have any device-related complications. And his conclusion was, total disc arthroplasty was an efficacious treatment for adjacent segment disease next to fusion. So then the question is posed, what role can total disc replacement play in the treatment of adjacent segment disease and scoliotic fusions? And if I'd have given this talk a month ago, it would have been more in vogue and a little more exciting, but frankly, this information was just published this week or this month in the Spine Journal, so if you've read the literature, you've seen this particular study. But I called my mentor, Dr. McAfee, and I said, look, there's nothing out there regarding this question, total disc replacement next to scoliotic fusions. And he said, he sent me back an email with a journal article he had just written. He said, it's pending publication, here's all my pictures, you can use them. And that's where most of this information comes from. So we have limited data regarding this type of treatment in this setting. But in theory, it makes sense, motion preservation below a long scoliotic fusion, and maybe halt the progression of that degenerative cascade. The question was posed by the SRS to Dr. McAfee whether or not it was safe and if we should even do trials. And as Dr. McAfee has a tertiary center really for disc replacement, and he gets referred to a lot of cases like this. And here's a patient who just really has a slight scoliotic tendency in the lumbar spine and was treated with a 2-level disc replacement for 2-level discogenic back pain. And you can see the scoliosis was accentuated with this particular unconstrained implant, which is the SB Charité. And here's another example, again, this patient was actually in the ProDisc study, who had single-level discogenic disease, but really a mild scoliotic tendency of 18 degrees that was made worse after the disc replacement to 25 degrees. So what they did was they analyzed disc replacement in the lab with their 6-degree of freedom motion analyzer and came up with this chart. And essentially what they did was they tested rotational stability at the treated level, in this case L4-5, as well as the level above and level below. And on the left side of the chart is single-level discectomy, Charité, and then Charité backed up with pedicle screws. On the right side is 2-level. So 2-level Charité, a Charité above a set of pedicle screws, and then adding an interbody device and adding pedicle screws to the Charité device. What you see here is total disc replacement does not restore rotational stability in the lumbar spine after you've done your ALL resection, your discectomy, and probably some release of your PLL. And after disc replacement, you have about 120 to 140% of the rotational instability of the intact segment. And if you do a 2-level, it increases to 240 to 260% rotational instability of the intact level. What's even more amazing is that if you have a disc replacement next to a segment that's fused, the rotation goes off the map. And so all that rotational instability is transferred to the next segment. The clinical correlation is that White and Pinjambi showed us that the tensile strength of the lumbar spine ligaments is in favor of the ALL, then PLL, then ligamentum flavum, then the capsular ligaments. And unfortunately, when you're doing this procedure, you have to sacrifice the ALL and probably some of the PLL. If you're not resecting the PLL, you're certainly releasing it above and below, and you're stretching it out. And then you probably unlock the facets as well because you restore some height. And all this basically leads to failure of restoration of rotational stability. Does a constrained device make a difference? The SB Charité, which is the unconstrained device, was made such that it would have an instantaneous axis of rotation that best mimicked the normal rotation of the disc. There are more constrained devices such as the ProDisc and the Maverick. They have less translational ability, and maybe they would protect against some of this accentuation of the scoliosis. But it does, in fact, clinically on X-ray, but the problem is that you start to stress the limits not of the bone implant interface, but of the implant-interplant face. And here was an example of basically having metal-on-metal articulation where it shouldn't occur. So in conclusion, lumbar total disc replacement, it tends to accentuate scoliotic tendency, and it's probably not a good idea in the treatment of transfer lesions distally. Thanks.
Now let me ask a question to JD. I just had intense interactions with the European colleagues, and this is way off the charts for the FDA to hear. But the latest postulation that my colleagues there had is they observed and acknowledged that the use of total disc replacements is probably a really bad idea in scoliotically deformed spines. But they've now come up with the total dynamic fixation model, where they put some dynamic fixation device into the back of the spine and put a disc arthroplasty in the front. Any comments, any suggestions on that?
I mean, there's very little experience. And one of the things I would say, that I didn't mention this in my talk, but a lot of times those caudal lesions aren't just degenerative disc lesions. So it's not just discogenic back pain that you're dealing with. Oftentimes, the degenerative cascade includes facet hypertrophy and ultimately stenosis, both in the foramen and in the canal. And if you're just doing, your motion preservation stuff, whether it's from the front or from the back or both sides, you're not going to address that pathology. And so you're really looking at trying to catch or almost prophylactically treat for segmental changes with these motion preservation products. And certainly that would add some stability. The biomechanical studies haven't been done yet, but that would add stability to your rotational segments by adding a posterior fixation system. But you'd have to do it early before you had secondary changes, and certainly if the patient has neurologic symptoms secondary to those changes, then you're looking at a big decompression and then probably extension of a fusion.